I'm really thrilled to introduce now Dr. Cara James, President and CEO of Grantmakers in Health, and previously directed the Office of Minority Health and actually pioneered a lot of the work early on that CMS is now building on. So Cara, hopefully all the tech is working and we can go ahead and bring you on camera and get your presentation started.
Can you hear me now?
Yes, we can.
Okay.
All right. Thank you for joining us. And we've had a lot of conversations about, I know, tech and data, certainly. And I know that's what you're here to talk about. So thanks again for being with us today.
Thank you. And let's hope the tech holds out here. So I wanted to talk today about our data and how health equity really does start with the data. And it's something that Dr. Seshmani mentioned in her comments of if you can't measure it, you really can't monitor it to track your progress, see where you have problems. And it's so interesting that we're having our conversation today, because when we think about all of the disparities that have been highlighted with the pandemic, and that this, as Dr. Seshmani mentioned, isn't a conversation that just started at that point, but we are at the 20th anniversary of the Unequal Treatment report from the Institute of Medicine, which really at that point in time summarized all of our knowledge related to healthcare disparities. And this slide that I'm showing you began really the launch of the National Healthcare Disparities and National Healthcare Quality Report, which shows you that while we have improved the quality of care for everyone in our country, we really haven't made any progress on disparities. So since that Unequal Treatment report came out and the launch of the very first National Healthcare Disparities and Healthcare Quality reports the following year, this shows you that overwhelmingly we are not making much progress and really need to think about how are we focusing on the quality improvement for everyone and closing those disparities. We know that the pandemic has highlighted disparities in COVID cases, mortalities, vaccinations, but also access to personal protective equipment, nursing home deaths, location in some cases of where testing facilities were, and access for underserved communities, who our essential workers were, who was affected most by unemployment and the loss of jobs, food insecurity, education, and the list goes on. Even though we have vaccines available and the boosters are available, data from last Friday shows you that we still have disparities in which we have large portions of the Hispanic population, as well as African Americans and American Indians, who are less likely to have received a booster, even though they are eligible at this point in time, and we still have vaccine disparities. One of the things that Dr. Seshmani also mentioned that we know is that the reasons for the disparities that we see are multiple and multifactorial. And when we think about those social determinants of health, thinking about what Healthy People 2030 lists, things like economic stability, education, access and quality, as well as social and community contexts, health and healthcare access and quality, as well as the neighborhood and built environment. These factors independently as well as collectively and at the intersection impact what we are seeing and the ability to achieve health equity. And addressing and making sure that we're advancing health equity really does require that we address all of these and not just thinking independently about certain factors. And as Dr. Seshmani mentioned, some of the work that CMS is doing, which is great, is to increase the availability of resources in languages other than English. And we know that in our country, 68 million people speak a language other than English at home. And about 28 million, 25 million of those individuals have limited English proficiency. So making sure that they can receive services as well as information in their preferred language will help reduce some of the disparities and increase their ability to navigate the health system to have better health outcomes. And just one other example, we don't have time to go through all of these, but when we think about the median savings for Medicare beneficiaries by race and ethnicity, one of the things that we note here is the large discrepancy between those who are white beneficiaries who have on median savings of about $118,000 compared to those who are Black and Hispanic. And for those of you who are paying attention, we don't have data for our Asian beneficiaries or Native Hawaiian, other Pacific Islander, or American Indian, Alaska Native. One of the challenges and why health equity starts with the data that we really don't know in some cases what's happening or have that insight into some of these communities. Why this is important, other than the obvious, but thinking about your ability to age at home or end up in an institution, your ability to pay for additional services that may be not covered by Medicare, and just health and quality of life. And as we're all going to the grocery store and thinking about the food prices, your ability to have healthy food choices for you. And so when we look at the data, we did this work in concert with the National Commission for Quality Assurance, NCQA, and really reviewed the data to see at federal levels what our completeness look like, what the standards are that are being used, and whether or not the data are publicly available. And there's a lot of information on this slide, but I want to kind of really focus your attention in this second column of the completeness, where you can see that for some of our data sets, such as Medicaid or federally facilitated marketplace and really commercial insurance, we're missing a lot of data. And while Medicare data for race and ethnicity is largely complete, those data are not necessarily using the standards that are currently in place, which are from the Office of Management and Budget from 1997. So our communities and populations have changed. We need more disaggregated data to look at the variability within communities and within populations. And we're still missing a lot of our data. And when we think about, again, our vaccines and where we are with COVID, we are missing a lot of race and ethnicity data. And again, what we have available to understand is critically important. So we provided some recommendations on what we can do to improve our data, to think about how we can make sure that as we go forward, we are better able to not only collect data on race and ethnicity, but also to think about the data for the social determinants. And as Dr. Seshmani mentioned, Medicare is looking at that for things related to food insecurity and housing and transportation. But again, all of those social determinants that are driving to provide a more complete picture of the individuals and the communities we're trying to serve. So what does it take for us to achieve health equity? You heard CMS's definition, which largely is very similar to some of the others that we have. I'm providing two here, the World Health Organization, where equity is the absence of unfair, avoidable, and remedial differences among groups of people related to a number of factors, many of which you heard in the CMS definition. And CDC's definition is the state in which everyone has a fair and just opportunity to attain their highest level of health. And when we think about what that means, it's not giving everybody the same thing or treating everybody exactly the same, because again, that intersection of a lot of the factors mean that the needs that people have vary. So we want to give people what they need to be able to obtain their highest level of health. That could be transportation services, it could be resources in languages other than English, it could be food or any other number of things. And when we think about what it means, we really need to make sure that health equity is a priority. It is currently for a number of organizations and for many in our country, not everyone, but for many. But we have seen some focus and attention before, and we need to make sure that it stays a priority. The reasons and the lessons and the things that have happened that led to the inequities that we have seen are not things that happened overnight, and they're not things that are going to disappear in a 30, 60, 90-day plan, or even in 1 or 2 years. So we need to maintain a focus and the resources to address these issues. We need to strengthen the role of leadership. We know that you as healthcare leaders, what you talk about in public and what you talk about even in private signals what's important and what you care about, and also signals to others where they should be focusing their attention. We need leaders who continue to lift up health equity, to focus on it, to make it a priority, and to allocate the resources to advance health equity. We need to engage our communities in humble inquiry. They know what the challenges are. They also have some ideas about solutions, and they can tell you and help work to develop solutions that are likely to succeed and understand what some of those potential pitfalls are. We need to support our data infrastructure and analysis. It is no longer okay for us to say we don't know. We have the capability, the capacity, and the resources to address our data gaps, and we need to make those steps happen. We also need to tackle those tough issues, thinking about those social determinants in the intersection, and also to look at the structural and systemic issues that are contributing to the inequities that we have. These are, without tackling these tough issues, we really are just tinkering at the edges and not likely to make meaningful progress. And we need to make health equity part of our standard operating procedures and create program and policy sustainability. We are in an unprecedented moment where we are very much focused on health equity and what it takes to achieve health equity. But we also realize this is a moment, a window of opportunity that is going to close at some point, and we want to make sure that the work continues, baking it in to what we're doing and making sure that it is part of how we just do business and not a special initiative that's led by whomever particularly focused on it. And finally, we need to develop a robust pipeline. As Dr. Shesmani mentioned, it's great that CMS is doing what it can to expand GME to rural and underserved communities, but we also need to get further upstream, because one of the things I have the pleasure of serving on the board of AAMC, and one of the concerns of the leadership there is looking at the cost for those individuals who are trying to go into residency and how that has increased over time. And even the cost of college. So this pipeline of those who are eligible to go into med school is one that has the potential to shrink. So how do we get further upstream so that we can have the diverse workforce that we are looking for and that we need, and also that we think about how we're training not only our physicians, but nurses, other healthcare executives, community health workers, public health, and so many who have experienced burnout in these last 2 years, and to make sure that we are filling our gaps in our health professional shortage areas or underserved areas. So getting further upstream, addressing those needs is critically important for us to really achieve health equity. There's a lot of work, and I think that one of the things that Dr. Shesmani mentioned that I just want to lift up again is that there's a role for all of us to play in this. These are not challenges that any one sector can solve alone, but ones that we all working collectively and collaboratively can address and really make sure that when we look back on this moment in a few years or in a decade, that we really have made lasting, sustainable progress to advance health equity. Thank you.